Okay. Now coming to the gestational diabetes mellitus. Okay. For this gestational diabetes mellitus, the key counseling points are there. So some women will be controlled with diet and exercise. We have to explain to these patients with GDM that some women will require only diet plus exercise, while most will require metformin or insulin. If not treated, there is an increased risk of shoulder dystocia. Okay. So what we have to do, we have to increase the monitoring, and interventions in pregnancy and labor are important. Okay. So there will be increased interventions during the pregnancy and the labor. Okay. So this is what is the main important management and in the counseling of patients with GDM, that there is a requirement of, there may be requirement of the metformin and insulin. If not treated, there is increased risk of shoulder dystocia, and we have to increase the monitoring as well as interventions in the pregnancy and the labor. Okay. So what are the risk factors which we need to look for in the booking visits? So at the booking visit, we will look for these high risk factors. The BMI more than 30 kg per meter square. If the previous baby is more than or equal to 4.5 kg, if there is a past history of GDM or the first degree relative having the diabetes mellitus, and if she belongs to the population where the high risk of diabetes is there, such as an Asian population. If any of these present, we will test these ladies for GDM. The timing of the testing is going to be very important, which we will discuss soon. Okay. So what we should not be used for screening, what is not used is a plasma fasting glucose is not used. Then random glucose, HbA1c, glucose challenge test, and urine glucose, they are not used for the screening. What is used is a OGTT, oral glucose tolerance test. Okay. So what about the glycosia, urea? Okay. So urine glucose is not used for the screening for GDM. Okay. But when you do the urine glucose, and if you find that there is a glycosuria, when to suspect the GDM? If there is a glycosuria of 2 plus or more at least once, or 1 plus or more on 2 or more occasions, we have to test, suspect the GDM and refer these patients for OGTT. Okay, so we will further do the OGTT on these patients. So the next step here, if scenario mentions that she has got a glycosuria of 2 plus, our next step will be to screen her by OGTT. Okay. Now, what is the test recommended? So test recommended is 75 grams of glucose, oral glucose tolerance test. So 2 hours, this 75 gram, 2-hour OGTT is done. Okay. So for which patients? Previous GDM, we have to, if she is a case of previous GDM, then we have two options. One, she will go for early self-monitoring and early OGTT. Okay. Or early OGTT. Now she is a case of previous GDM. Then we have to screen this lady for GDM. Okay. And she has got for monitoring. One, she will do the self glucose monitoring, and or she can go for early OGTT. Okay. So if initial OGTT is normal, we'll repeat this OGTT at 24 to 28 weeks of gestation. So when these risk factors are present, we will do the OGTT at 24 to 28 weeks of gestation, except in cases of previous GDM, where we will do the testing quite early. Okay. Early at booking or in the first trimester, we will do the OGTT. If it is normal, then we'll repeat at 24 to 28 weeks of gestation. Is it clear?
Clear.
So early OGTT is indicated for previous GDM. Okay. And if it is normal, then we'll repeat at 24 to 28. And other risk factors, OGTT will be done at 24 to 28 weeks of gestation. So have you understood the significance of the risk factors? These risk factors are important from screening for the GDM. Out of those risk factors, GDM is the only risk factor. Previous GDM is the only risk factor where we will do the screening early at booking or in the first trimester. If it is negative, we will repeat at 24 to 28 weeks of gestation. And for other risk factors, we will do the screening at 24 to 28 weeks of gestation. So if you are asked about the question, look for which high risk factor you are taking into account as far as the timing of the OGTT is concerned. They will ask you about the timing of OGTT, but for which factor? If it is a previous GDM, it will be at booking or first trimester. And if normal, then you go for, so look for complete answer. Okay, the recommended OGTT screening for lady with previous GDM will be, if your option says at booking or first trimester, that can be one option. Other option can be booking or first trimester. If negative, repeat at 24 to 20, then that will be the best option. You got it? Is it clear?
Yes,
Yes,
sir.
Yeah, look for the best option. That is what I just want to say. Okay. Now, what are the cutoffs for the diagnosis of GDM? Okay. So, fasting plasma glucose more than or equal to 5.6 millimoles per liter, and 2-hour OGTT value more than 7.8 millimoles per liter. Okay. Remember 5, 6, 7, 8. Okay. These are the values you should remember: 5, 6, 7, 8. So, fasting 5.6, 2 hours 7.8. Okay. So, if these values are equal to or more, then we will diagnose, and this either value is sufficient. Okay, so it is not both values, it is either value is sufficient. Okay, this you should remember. So fasting more than or equal to 5.6, 2-hour OGTT more than or equal to 7.8. Okay, now after the diagnosis, what you are going to do? Now you have screened these ladies, she is found to be diabetic, the cutoffs you know. Okay, now again, do not confuse these cutoffs with the preconceptional cutoffs for the fasting and pre-meal. Okay, in a diabetic patients, we have discussed the cutoffs of the blood glucose in the fasting period and in the pre-meal period. Fasting between 5 to 7 and
to
pre-meal between
7, 4
4
to
to
7.
7. Okay, and never it should drop
Okay.
below 4. Okay, and these are the
Hmm.
OGTT cutoffs. Okay, so because you know, when you have an answer, you have all the values, and you get confused under the stress. That is why I'm emphasizing here and here. Okay, so after the diagnosis, immediate action will be that she will go for joint diabetic plus antenatal clinic within 1 week and inform the primary care team. So the next step will be diagnose GDM, should come to the joint diabetic plus antenatal clinic within 1 week. Okay, so both the care are given at the same visit. Okay, so patient counseling will be done. We have to discuss about the short-term and long-term risk. Importance of glycemic control we have to emphasize, because that reduces the incidence of the macrosomia, birth trauma, induction of labor, cesarean section. That is the operative intervention chances are reduced. Neonatal hypoglycemia and parental deaths will be reduced. Okay, so the most important is teaching. Okay, so teach self monitoring of the glucose, and she will be started on diet plus exercise, and she will also be referred to the dietitian. So she will come to the joint diabetic clinic. She will be given the advices what is the importance of this glycemic control, and she'll be given the diet plus exercise advices, referral to the dietitian. So a healthy diet, switch to the low glycemic index foods, exercise, regular activity, especially 30 minutes after waking after the meals. 30 minutes walking after the meals is advised. Okay. Now, what are the glucose targets? Okay. So these targets will be same as pre-existing diabetes mellitus. Fasting should be less than 5.3 millimoles per liter. 1 hour post meal should be less than or equal to 7.8, and 2 hour post meal should be less than or equal to 6.4 millimoles per liter. So any patient who is on either of the treatment, like diet plus exercise, or maybe on insulin, or maybe, so these are the treatment targets. Okay, these are the treatment targets. Fasting should be less than or equal to 5.3. 1 hour should be less than or equal to 7.8, and 2 hours should be less than or equal to 6.5. Okay, and important thing is that maintain glucose always more than 4 millimoles per liter to avoid the hypoglycemia. Okay, so stepwise management of the GDM. First step is diet plus exercises. If her fasting level, glucose level is less than 7 millimole per liter at the diagnosis, the trial of lifestyle therapy is indicated. Again, this is a SBA, so they'll give you the long scenario that she is screened for the diabetes mellitus. They will ask you to interpret, okay, values of this blood sugar. Okay, and she is found to be then GDM, then what will be her management? Okay. So if the fasting is less than 7 millimoles per liter at the time of diagnosis, she will be given the trial of lifestyle therapy, that is diet plus exercise. Okay. Metformin will be added in the step 2 if the targets are not met within 1 to 2 weeks. So 2 weeks of the diet plus exercise if the fasting is less than 7, please remember. Okay. So if the not control with the diet plus exercise in 1 to 2 weeks, we will add metformin. Okay, that is the first line pharmacotherapy. It is off label, but it is recommended. Okay, it is recommended during pregnancy also. Third step is insulin. Okay, so metformin, what are the indications of insulin? Either metformin is contraindicated or not tolerated. There is a failure of metformin plus lifestyle, or initial fasting is more than or equal to 7 millimoles per liter, then we will start immediate insulin. That is why I mentioned that they will say give you the diagnosis of the gestational diabetes mellitus, and they will give you the value of this fasting glucose. So fasting glucose less than 7 millimeter, it will be lifestyle modification. Okay, diet plus exercise. If not controlled, go for metformin. If not controlled, go for add insulin. Okay. But if the fasting is more than 7 at the beginning only, then immediate insulin is required. And the most important, the confusing, and generally they are asking in the examination, is a fasting value is given between 6 and 6.9. And if she is having associated complications such as macrosomia or polycythemia, so she will be given maybe around 32 weeks of gestation, and you may be given a scan with the expected birth weight, which is more than 95th percentile for that particular gestational age, with the HbA1c value of fasting value of 6.8. Okay, then what is the management? You have to start immediate insulin. So fasting between 6 to 6.9 plus associated complication, you will go for immediate insulin. Otherwise, if there is no complication, she is below 7, we'll go for diet plus exercise. Okay. So I hope the concept is clear. Okay. The same thing is discussed here. Fasting less than 7, go for stepwise diet, metformin, insulin. Fasting more than or equal to 7, immediate insulin plus may be required metformin. Okay. Fasting between 6 to 6.9 plus complications, consider insulin therapy. Okay. Now coming to the antenatal care. Okay. So glucose targets during the pregnancy, fasting should be less than 5.3 millimoles per liter. 1 hour post meal should be less than or equal to 7.8. 2 hours should be less than or equal to 6.4. And always avoid blood sugar less than 4 millimoles per liter. So these values, target values, treatment values we have seen. Okay. Now, how frequently we need to monitor these patients? Okay. Type 1 diabetes patients, this is also SBA unit. Please remember. Okay. So type 1 diabetes, how many times we are going to monitor? So these patients, type 1 diabetes patients, will be on insulin. Okay. And any patient on insulin, whether it is a type 1, type 2, or GDM on insulin, she will be always following this protocol. Okay. You will have fasting, pre-meal, 1 hour post-meal, and bedtime. So this is a 7 point protocol. So in 7 times in a day, we have to measure. Okay, fasting plus pre-meal, that means you will measure fasting, that will become a before breakfast, then after the breakfast. Okay, then before lunch, 1 hour after the lunch, before dinner, 1 hour after the dinner, and one bedtime. So this becomes a 7 point control. I hope this is clear to you. Now, if she's a type 2 or GDM on insulin, the same will. So any patient who is on insulin, type 1 diabetic, type 2 diabetic, or GDM who is on insulin, she will require 7 point monitoring. Okay. But if she is a type 2 or GDM, she is managed only with a diet or oral therapy, you need a fasting and 1 hour post meal, that is 4 point. Okay. So you will do the fasting, then breakfast, lunch, and dinner, 1 hour post meal. So 4 points will be required. I hope this is clear to both of you. Is it clear?
Yes, sir. So
Yeah.
please repeat once.
Yeah. Suppose your patient is type 1 diabetes mellitus or type 2 or GDM, but she is on insulin, then she will require intensive monitoring 7 times in a day. Okay, that is 7 point monitoring. Okay, we will be doing the fasting. Okay, fasting means before the breakfast. Then after the breakfast will be 1 hour post meal. Okay, then uh, pre-meal will be there before the lunch. Again, post lunch will be there one more. These are four. Okay, then pre-dinner will be there. Fifth, 1 hour post dinner will be there. Okay, that will be sixth, and another at bedtime. So that will be 7 point monitoring. Okay.
Okay.
And if she is a type 2 diabetes or GDM, which is managed only with a diet or oral therapy, that is metformin, we will require 4 times monitoring. That is one we will do at fasting. That will be same as before the breakfast. Then we don't have to do pre-lunch and pre-dinner. You got it? We also don't have to do bedtime. Only 1 hour post meal. Breakfast, lunch, dinner. 3 values plus fasting. 4 times. You got it? Clear?
Okay.
Any patient with diabetes plus oral therapy monitoring, fasting, and 1 hour post lunch 4 times. Okay. So they have to keep the record, and all these record we are going to analyze. Okay. Now, this 2020 update talks about this continuous glucose monitoring. Okay. So all type 1 diabetes, we will be offering real-time continuous glucose monitoring. Okay. So this real-time glucose monitoring, type 1 diabetes, they have the high glycemic variability. There are high chances of hypoglycemia because there are lots of fluctuations in the glucose level. And that is why the real-time glucose monitoring is important. So continuous glucose readings every few minutes will be taken with this real-time continuous glucose monitoring. And that will give us the alert regarding the hypoglycemia as well as hyperglycemia. Okay. There is another way of monitoring the glucose, that is a flash glucose monitoring called as, it is an intermittently scan glucose monitoring. So intermittently you will get the values of the glucose, but this is not indicated. What is indicated is real time continuous glucose monitoring. Okay, if at all this is to be offered, you offer real time, not the flash one. Okay, that is an only alternative if it is not possible, or if the patient is not willing for continuous real time monitoring, then go for flash monitoring. Okay, so it is to be considered in recurrent hypoglycemia and unstable sugars. So if the patient is having recurrent hypoglycemia and unstable sugar, you will advise real-time CGM. Okay, so real-time CGM for all pregnant type 1 diabetics. This is advice real-time, and alternative only if this is not possible, then go for flash glucose monitoring. Okay. Then coming to the insulin therapy during pregnancy, it is safe, rapid and acting. You have aspart and lispro. Basal is NPH, that is the first line. So if the patient is already on detamir or glargine, then it can be continued. Okay, so the first line will be the basal or NPH. Then aspart and lispro, if there is a postprandial hyperglycemia, that can be controlled with this rapid acting. And this determinant glargine, we will not be starting during the pregnancy if she's already not taking this. But if she's already taking this, and if there is a good glycemic control, we will continue during the pregnancy. There has been a question on this particular. So the first line will be the NPH, you remember. Okay. And this will be the for the postprandial hyperglycemia. Do not select detamir or glargine. Okay, unless the patient is already taking and she is having the control on it. Okay. So use NPH as a first line basal insulin, add rapidly acting for meals, and continue long acting analog if she is already achieving the glucose control. Okay. And another, when she is on insulin, we have to go for rotation of the injection sites for injecting the insulin, because that will prevent the cutaneous amyloidosis. Okay. Then hypoglycemia in pregnancy. It is quite common in the first trimester. And not only that, the symptoms, they are impaired in pregnancy. Okay, like palpitation, sweating, they may not be there. Always carry the glucose and provide glucose kit. Okay, glucagon kit, sorry, for these patients. Then ketone testing, all type 1 diabetics should be tested for ketone, especially when there is a hyperglycemia or there is a illness. We have to test for the ketonuria. Okay, and suspect diabetic ketoacidosis and immediate admission to the level 2 care. So whenever there is a suspicion of the diabetic ketoacidosis, we will admit them to the level 2 care. Okay. Now, HbA1c in pregnancy. When it will be done? One, it will be done at booking. That will help us to stratify the risk. Otherwise, HbA1c monitoring during pregnancy is of no use. Okay. Routine monitoring in the second and third trimester, it is not useful because we are monitoring these patients on glucose. So if you are keeping her glucose within normal range, then definitely HbA1c will always be normal. It is not required. But at the time of diagnosis, you will be able to stratify the risk. That is why at the booking, it is required. Okay. Now coming to the now we are talking during the pregnancy. Now during the pregnancy, retinal care and renal care. Okay. So retinal care will be in the first visit if it is not done in the last 3 months. Okay. So again, there can be question on this. They'll give you the scenario. The patient has attended the preconception counseling. Her last retinal screening was done 5 months before the conception. Okay. Then what are the tests when it is to be done? So it should be done in the first visit. If it is done in the last 2 months, then you don't have to do at the first visit. Okay. So you will do it in the first visit if it is not done in the last 3 months. Then if this first visit or the last visit has retinopathy, then you will do at 16 to 20 weeks if there is a retinopathy diagnosed. Okay. And otherwise we will do it at 28 weeks. So first thing you will do in the first visit, if this retinal screening is not done in the last 3 months, you will do it in the first visit. If it shows retinopathy, you will repeat between 16 to 20 weeks. But if there is no retinopathy, you will not do at 16 to 20 weeks. You will do at 28 weeks. I hope this is clear to you. Okay.
Yes. Yes.
Bina madam, should I explain?
Yeah.
Should I explain?
No, I
Clear.
understand.
Yeah. So it not a contraindication to the rapid glucose control or vaginal delivery. Okay. Then coming to the renal care. At booking, you will do the serum creatinine. You will also look for albuminuria, and you will refer to the nephrologist if creatinine is more than or equal to 120 micromole per liter. Albumin to creatine ratio is more than 30 milligram per millimole, and protein urea more than 0.5 gram per day. So preconceptional, it was a EGFR less than 45. Okay, here they are counting along with creatine and ACR, the proteinuria is counted here. Okay, so do not use EGFR in pregnancy. Okay. Now coming to the pre-eclampsia prevention. For pre-eclampsia prevention, we will start low dose aspirin 75 to 150 milligram at 12 weeks and will continue till 36 weeks of gestation to reduce the risk of pre-eclampsia. The fetal monitoring will be done at structural scan will be done at around 20 weeks of gestation. And growth scan at 4 weeks of gestation every 4 weekly from 28 weeks to 36 weeks we will be doing. Okay. Routine CTG Doppler not recommended before 38 weeks of gestation unless there is a FGR risk. Okay. Now delivery risk in patients with GDM. Maternal will be the need for induction, cesarean section, birth from. Fetal risk will be macrosomia, shoulder dystocia, and neonatal hypoglycemia. So these are the delivery related. One is a maternal operative risk, and fetal will be macrosomia, shoulder dystocia, and neonatal hypoglycemia. Okay. So what is the organization of the care? She should be seen in the joint clinic, that is diabetes plus obstetric team. Her follow-up will be every 1 to 2 weeks. And she will be given a timetable of antenatal visits. This also you should remember what kind of antenatal visits this lady should have. Okay. So multidisciplinary, that is joint diabetes plus antenatal clinic. We need to discuss about the maternal risk, fetal risk, breastfeeding, and neonatal care. If no preconception care is taken, full complication screening for neuropathy, retinopathy, nephropathy, vascular disease we have to do. review the medication, stop if any teratogenic drugs she is taking, investigate with HbA1c for risk stratification, retinal assessment if not done within 3 months, renal assessment for ACR and creatinine, because EGFR during pregnancy we don't do. Then dating plus viability scan at around 7 to 9 weeks of gestation. And if she is a previously GDM, then she will have either early self monitoring of the blood glucose, or she will go for early OGTT. If early OGTT is negative, then we will repeat that OGTT around what weeks of gestation?
24 to 28 weeks.
24 to 28 weeks of gestation. Okay. Follow-up will be every 1 to 2 weeks. Okay. And retinal assessment, if retinopathy is present initially, if she is a previous GDM or if she is late booking, then we will do the early testing at 16 to 20 weeks. Okay. If she is a case of previous GDM, then, or if she is late booker, then we will do the previous GDM and late booker. Then we will do that at 16 to 20 weeks of gestation. 20 weeks, we will do the anomaly scan. Detailed scan will include 4-chamber heart, outflow tracts, and 3-vessel view. Okay. At 28 weeks, growth scan plus AFI, retinal assessment will be done. Then GDM diagnosed at 24 to 28 weeks will enter this pathway. So from 28 week onwards, all these high risk we are going to screen at 24 to 28 weeks of gestation. If any of these patients will be diagnosed GDM, they will start their follow-up from here 28 week onwards. Okay, so at 32 weeks there will be growth scan plus Likert scan, routine antenatal care. At 34 weeks there is no specific difference. 36 weeks we have to counsel one about the mode and timing of delivery, analgesia and anesthesia, glycemic control in the labor, neonatal care, breastfeeding and contraception. Okay. Between 37 to 38.6 weeks of gestation, we will offer delivery, either induction of labor or cesarean section to type 1 or type 2 diabetes mellitus. So if the lady is a type 1 or type 2 diabetes mellitus, the delivery time is between 37 to 38.6 weeks of gestation. Okay. 38 to 39 weeks of gestation, the fetal well-being will be continued if she does not deliver or she is a case of GDM. And for GDM, we will deliver by before 40.6 weeks of gestation. So we will not allow these patients to go beyond 41. Okay. So they will not become 41 weeks. We will advise the termination by around 40 plus 6 weeks of gestation. Okay. Then preterm labor in diabetes. Tocolysis is not contraindicated, steroids are not contraindicated, but steroids cause increased blood glucose, so we need to adjust the insulin dose accordingly. What we need to avoid is the beta mimetics such as terbutaline. They will increase or worsen the hyperglycemia. Coming to the intrapartum care, the timing of delivery we have discussed. Pre-existing diabetes, that is type 1 or type 2 diabetes, we will deliver between 37 to 38.6 weeks. GDM less than or equal to 40.6 weeks of gestation. Mode of delivery is to be individualized. Okay, so only diabetes is not a direct indication for cesarean section, but we need to take into account macrosomia, previous cesarean section, and obstetric factors. These factors are to be taken into account. However, when there is no macrosomia and other no complication, VBAC is not contraindicated in diabetes. So please remember from labor point of view also, these patients can have VBAC provided considering her BMI and everything is as per that particular limit. Okay. Then coming to the blood glucose control in the labor. So target is between 4 to 7 millimoles per liter. Monitoring is always 1 hourly glucose monitoring will be done. For type 1 diabetes mellitus, consider IV insulin plus glucose, dextrose, and all diabetes mellitus IV insulin if not controlled. So, okay. So type 1 diabetes mellitus, you have to start them on dextrose plus insulin drip. But rest of the other patients, you will go for hourly glucose monitoring. And if hourly glucose monitoring is not getting monitored or the glucose is not monitored, getting controlled, then you go for IV insulin if it is not controlled. Okay, but type 1, you have to go for IV insulin plus dextrose. Okay, during late labor, during late antenatal visits, we have to consider, or even in early labor, early assessment of anesthesia from if the lady is obese or if there is an autonomic neuropathy, we'll consider the anesthesia review in early labor or even in late antenatal period. Then if she is under general anesthesia, we have to monitor the blood glucose every 30 minutes. So labor monitoring every 1 hour. Under anesthesia, every 30 minutes we have to monitor. Okay. Then coming to the neonatal care, the patient should be delivered in a facility where 24-hour neonatal resuscitation facilities available. Baby should stay with the mother unless there are complications. Routinely, blood glucose is to be tested at 2 to 4 hours for the baby post delivery. Okay. When to admit in the NICU? If there is a hypoglycemia along with symptoms, respiratory distress, cardiac issues, encephalopathy, polycythemia, feeding difficulty, IV fluids required, jaundice needing phototherapy, and preterm less than 34 weeks, we will admit the baby in the NICU. Then preventing neonatal hypoglycemia, the baby mother should feed the baby within 30 minutes of the birth and then every 2 to 3 hours. The baby's blood sugar should always be more than or equal to 2 millimoles per liter and escalate IV dextrose if there is a persistent blood sugar less than 2 millimoles per liter or if there are symptoms which are present, hypoglycemia symptoms present. Okay. Now postnatal care. This is very important. Please concentrate here because there are SBAs or EMQs in this section. Then what will be the monitoring in the postnatal period? What about the insulin in the postpartum period? For type 1 and type 2 diabetes, reduce insulin immediately after the birth. Okay. High risk of reduce insulin immediately after the birth if she is type 1 or type 2 diabetic. There is a high risk of hypoglycemia, especially if she is breastfeeding. So we need to advise snacks before or during the feeds. Okay. So during the breastfeeding, there are high chances of hypoglycemia and we have to reduce the insulin immediately after the birth. Okay. But if she is a case of GDM, we'll stop all glucose lowering drugs immediately. Here, we will reduce insulin. Here we will stop our glucose lowering drugs. Okay. So women with pre-existing diabetes, their immediate postnatal plan will be refer back to routine diabetes care team. So she will be refer back to the routine diabetes care team if she is a case of pre-existing diabetes. For future pregnancy planning, we need to emphasize about the contraception, need for preconceptional care, and key messages: do not conceive without optimization of the glycemic control. Women with gestational diabetes mellitus, before discharge, we will do the blood glucose and exclude the persistent hyperglycemia. This postpartum management, generally they ask you what follow-up is indicated for these patients. So before discharge, we will do the blood glucose. We will exclude the persistent hyperglycemia. We will also do the patient education, counsel regarding the symptoms of hyperglycemia such as polyuria, polydipsia, fatigue. Then explain the future risk counseling. Explain that high risk of recurrence in the future pregnancy and they have the increased risk of type 2 diabetes. Okay. So what will be their plan? Early screening in the next pregnancy if they are planning future pregnancy. Second, the postnatal testing. This is the important part from the examination point of view. When will you do the testing for these patients? Postnatal for GDM, you have to test these patients between 6 to 13 weeks postpartum. Usually at 6 weeks visit they are tested. So 6 to 13 weeks postpartum, you will advise the follow-up. The test which is preferred is a fasting plasma glucose, and okay, that is the preferred test. If that is not feasible, then you go for HbA1c. Okay. So important is that do not routinely use OGTT postnatally. So here postnatally we do not use OGTT. We use fasting plasma glucose. Okay. And if that is not feasible, then we go for HbA1c. Now this is the question which generally they ask uh, about the management. They will give you that either she is screened in the postnatal period between 6 and 13 weeks of gestation and her fasting plasma glucose was this, or her HbA1c value was this. Then what will be the further advice? Okay. Management after normalization of the glucose. One, about the lifestyle interventions such as weight control, healthy diet, regular exercise, and prevention strategy such as they will be referred to the diabetes prevention program. Okay. Now, interpretation of the fasting plasma glucose. Just now we have discussed what we will do. We will do the fasting blood glucose level between 6 and 13 weeks of gestation postnatally. Okay, 6 and 13 weeks postnatally, and that particular level is less than 6 millimoles per liter. That means she is low risk, so she will go for annual screening for for diabetes. Okay, then if the value is between 6 and 6.9 millimoles per liter, that means she's a pre-diabetic and she has got a high risk of development of the type 2 diabetes. She will have the intensive lifestyle program plus prevention, intensive lifestyle plus prevention program. There is a specific diabetes prevention program, which is a structured program with the specific goals. Okay. So it is not only her own managing the lifestyle, but it is a structured way, the program she will be referred. Okay. But if the value of fasting glucose is more than or equal to 7, that means she is likely to have the type 2 diabetes, that is a confirmed diabetes. So we will be referring her to the diabetes team. Okay. Now, instead of fasting blood glucose, if we have done the HbA1c, then as per the HbA1c, if HbA1c less than 39 millimoles, then she is low risk. She will go for annual follow-up. If it is between 39 to 47 millimoles, she is high risk. She will be advised prevention program for the diabetes. And if it is more than 48 millimoles, then she is a case of diabetes and she will be referred to the diabetic care. Okay. So both values and their interpretation you remember, because these are the frequently asked questions. Okay. So postnatally, we have to screen these ladies for the detection of the high risk for the development of the type 2 by doing fasting plasma glucose, and with the fasting plasma glucose less than 6 is a low risk, between 6 to 6.9 she is a pre-diabetic, she will be requiring diabetes prevention program plus lifestyle, intensive lifestyle, and more than 7 she is a diabetic. Okay, with respect to HbA1c, it is less than 39, she is low risk, less than or equal to less than 39 is low risk, 39 to 47. Okay, so please remember these HbA1c values also. You remember these, okay, both millimoles also and HbA1c values also. 5.7 to 6.4, that is 39 to 47. She is high risk. She will go for prevention program. More than 48, that is more than or equal to 6.5. She is diabetic. She will be referred to the care. Now coming to the long-term follow-up. Long-term follow-up, she will be on annual HbA1c. Okay, and lifestyle advice, diet, exercise, weight control, etc. Future pregnancy, she will be going for early screening and self-monitoring or OGTT in early pregnancy. If initial test is normal, we will repeat OGTT at 24 to 28 weeks of gestation. Okay. Then from examination point of view, take-home messages, check glucose before discharging GDM. Postnatal test fasting plasma glucose at 6 to 13 weeks is to be done. OGTT is not done routinely postnatally. Annual HbA1c mandatory follow-up. Then high recurrence risk in future pregnancy. Counsel for contraception plus preconceptional care. Fasting plasma glucose more than or equal to 7 millimoles per liter. Likely type 2 diabetes. Type 1 and type 2 diabetes mellitus, delivery time between 37 to 38.6. GDM 40.6, labor glucose target between 4 to 7 millimoles per liter, neonatal hypoglycemia. So feeding is early, that is advised within 30 minutes. GDM, stop treatment postpartum. Steroids increase insulin requirement. Beta mimetics are contraindicated. HbA1c not used routinely in the second and third trimester. Okay. OGTT is the only diagnostic test. HbA1c is not a screening tool. Insulin, if fasting is more than or equal to 7 millimoles per liter. GDM diagnosis, fasting more than more than or equal to 5.6. Avoid EGFR in pregnancy. Routine CTG not required. So OGTT is the diagnostic test, and cutoff for OGTT you should remember 5, 6, 7, 8. Okay, that cutoff you should remember. Then another thing you should remember, HbA1c target should be less than 6.5. Avoid pregnancy if the HbA1c is more than 10%. So preconceptional target should be less than 6.5. More than 10% pregnancy is to be avoided. Folic acid should be started 5 milligram preconceptionally. Insulin of choice is a isophane. Metformin is allowed. Stop AC inhibitors, ARBs, statins, then retinal exam before rapid glucose control, glucose testing for type 1, plus whenever there is a illness or hyperglycemia, pregnancy must be planned and contraception should be advised until the control is obtained. Screening test, uh, not GCT, it is OGTT only. Okay. Then diagnosis 5, 6, 7, 8. This is just we have mentioned. Glycosuria threshold 2 plus once or 1 plus more than twice. Okay. First drug is a metformin. Immediate insulin if the fasting is more than or equal to 7 millimole. Target should be less than 5.3 fasting. 1 hour should be less than 7.8. Okay. HbA1c use at booking only. Okay. So this is what is there are so many values. So please do not get confused. Okay. Note down these values and remember. Okay. We will solve few SBS. Who wants to read?
I will start.
Yeah.
A 29-year-old woman with type 1 diabetes is planning pregnancy. Her hemoglobin A1C is 7.2. What is the most appropriate advice? Avoid pregnancy until A1C is less than 5.5. Continue attempts as A1C is less than 6.5. Start insulin pump. Stop metformin. Delay pregnancy until A1C is less than 6. So, since A1C is 7.2, she is diabetic, so she should start the insulin. C should be the answer.
Delay pregnancy to less than 6. Actually, it is
Delay
less than
pregnancy and
6.5.
Actually, it is 6.5 here.
This is 6.5.
It should be
Nearest option
6.5.
E.
Okay.
so then what is the
Option they
answer?
have given B. Target HB is target is less than 6.5%. So because she is a type 1 diabetes, she is planning pregnancy. Here, continue attempts as HbA1c is less than 6. This is the wrong answer. Her HbA1c is 7.2.
Yes, the
Okay.
answer, the question is not clear.
It should be 6.2. This should be 6.2.
Yes, then
Yes.
she can attempt
Mm.
because A1C will be 6.2.
Okay.
Yes, sir. So that is why I was confused
Yeah.
a little bit.
Next.
A woman with diabetes has hemoglobin A1C of 10.5. What is the best advice? Continue attempts at conception, start folic acid, avoid pregnancy until A1C is reduced. So C should be the answer.
The option.
Yeah. HbA1c more than 10%, strongly advised not to conceive. And how frequently you will monitor HbA1c during preconceptional period? If the
Monthly,
HbA1c is high,
monthly.
Monthly.
monthly, okay?
Yes.
So you have to monitor these patients, bring the HbA1c below 6.5, then you stop the contraception and then the actively they can plan. I hope the things are clear. Preconceptional, antenatal, intrapartum, everything we have discussed. Postpartum. Next.
Sir, there is one confusion. Can I ask?
We will discuss at the end, doctor.
Or
We'll
later.
finish this.
Okay. Which medication is safe to continue during preconception? One, glibenclamide, ACE inhibitor, statin, metformin, ARB. It is metformin.
D.
Yes.
D option.
Metformin is safe.
Then which insulin is first choice long-acting insulin in pregnancy? Glargine, tetramin, isofen. So sir, C, it is the isofen
Isofen
insulin.
insulin. NPH is safe. Yes.
Yes.
Next.
Which statement about rapid-acting insulin analog is true? Contraindicated in pregnancy, associated with an AMIS, no adverse effect demonstrated. So it is the C, no adverse effect demonstrated. Rapid acting insulin analog. If
Yes.
the patient is
No.
stable on them, then we
Yeah.
should continue.
We continue.
Otherwise,
Yes.
yes.
Next.
A woman with diabetes is planning pregnancy. Which drug should be stopped? So, metformin, insulin, folic acid, it is a D, ACE
D
inhibitors,
option.
it should be removed.
AC
So, we
inhibitors
stop.
we have to stop. Next.
which is not a risk factor for gestational diabetes. BMI more than 32, previous baby 4.6, first degree relative with diabetes, A1C 5.8, so it is D,
D.
A1C
Yes,
5.8%.
yes. So HbA1c is not used. First thing, it is not used for the risk assessment at all. So the next criteria was a Asian origin, or the patient
Ethnicity
is,
is
yeah, ethnicity is the another criteria. Next.
which test is recommended for screening GDM? So
D.
it is random blood sugar, A1C, urine glucose. It is D 75 gram OGTT.
D.
Yes, for screening, it is always 75 grams of OGTT, but postnatal it is not used. Postnatal it is a
Fortunately, it is
fasting,
not is the fasting blood sugar.
that is for
6
screening for
weeks or
type 2.
6 to
Yeah,
13
next,
weeks.
yeah, next.
Sanchana, would you like to read?
Yeah, this
Sure.
next question.
A pregnant
Sanchana,
woman.
Sinchana,
go ahead.
yeah, Sinchana doctor.
Pregnant. Yes, I am reading the questions. A pregnant woman has glycosuria 2 plus on one occasion. What is the next step? A. Ignore. B. Repeat urine. C. HbA1c. D. OGTT. E. Random glomerular. D. We should perform OGTT.
Yeah,
OGTT.
glycosuria 2 plus on one occasion, or 1
Or
plus
1
on
plus
more
on
than
2
two,
occasion.
two or
Okay.
more occasions. You go for
Yes,
OGTT. Okay.
yes, yes, sir.
Yes. A woman undergoes OGTT. The results are fasting is 5.4 millimoles per liter and her 2R is 7.9 millimoles per liter. What is the diagnosis? A. Normal. B. Impaired glucose tolerance. C. GDM. D. Type 2 diabetes. E. Repeat the test. It is C. GDM.
Yeah,
Yes.
because either value is,
Either of the one is.
yeah,
Mm.
okay.
5, 6,
Mm,
7, 8.
next.
A woman with GDM has fasting glucose of 6.5 millimoles per liter with polyhydramnios. What is the best management? A. Diet only. B. Metformin. C.
Yes.
Insulin plus or minus metformin. D. Repeat OGTT. E. Induce labor. It is C. Insulin plus or
Insulin.
minus metformin.
Metformin.
C.
Yes.
Yeah, but they have not given the gestational age or anything. Otherwise, labor related option could also be there. Okay.
Mm.
Next.
A woman with GDM has a fasting glucose of 6.2 millimole per liter. No complication. Initial management. A. Insulin. B. Metformin. C. Diet plus exercise. D. Immediate C-section. E. Sulfonylurea. It is C. Diet plus exercise.
Yes. What is the theme or principle here? Less than 7. The first step is a diet plus
Diet and
insulin
exercise.
Lifestyle.
trial. Sorry, diet plus exercise trial for 2 weeks. If not control, add metformin.
Metformin.
If not control, go for
Insulin.
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 Okay.
When should insulin be started? Immediately in GDM? A. Fasting more than equal to 5.6, fasting more than equal to 6, fasting more than equal to 6.5, fasting more than equal to 7, postprandial more than equal to 7.8. It is D. Fasting
D.
more than equal to 7.
Yes. Yes.
Which
Next.
glucose monitoring regimen is appropriate for GDM on diet control? A. Fasting only. B. Postprandial only. C. Fasting and 1 hour post meal. D. Full profile including bedtime. E. Weekly monitoring. It is C.
A.
Fasting with 1 hour post meal.
Yes.
4 samples.
GDM fasting plus 1 hour, total 4 points. Okay.
Yes.
Type 1 or any patient, type 1, type 2 or
Insulin.
GDM on insulin, 7 point.
7.
Okay.
7. Yes.
Yes. Which statement about HbA1c in pregnancy is correct? It is used for GDM screening. B. Routinely used in third trimester. C. Used at booking in pre-existing diabetes mellitus. D. Best marker for glycemic control in late pregnancy. E. Used instead of OGTT. It is C. Used at booking in pre-existing diabetes mellitus for
Yes.
risk
Yes.
stratification.
For risk stratification only. Okay. Now we have few EMQs, doctor. You can go ahead, doctor.
Yes. Woman with GDM is advised target fasting glucose pre in pregnancy, which is the target fasting glucose. It is
A.
fasting less than equal to 5.3.
A fasting less
A.
than or equal to
Target fasting
5.3.
glucose in pregnancy, GDM. Yes. Yes. Or yes, that is the only value.
Yes.
Yes.
Next.
A woman with GDM has fasting glucose of 7.2 millimole per liter at diagnosis. The options, please.
Fasting 7.2.
It is E, sir. Immediate insulin plus or minus metformin.
Yes, immediate insulin plus or minus. Next.
A woman with GDM has fasting glucose 6.3 millimoles per liter with macrosomia. Still, it is E, sir.
Early
Insulin.
insulin. Early insulin
Because the
consider, yes.
complication is
The
first.
guidelines is consider early insulin. That so we
Pregnant
should
woman,
remember that there is a difference between the two. Consider and starting. Okay, next.
yes. A pregnant woman with type 1 diabetes is advised glucose monitoring regimen. Options, please, sir.
Glucose pregnant women type 1. Glucose monitoring type 1.
7.
We have discussed this.
Just 7 samples.
Full profile monitoring. J.
Yeah, full profile. Fasting,
Mm.
pre-meal, post-meal, and bedtime. Okay.
Yes, yes.
So again, the few things to remember. OGTT is only diagnostic test. GDM diagnosis criteria is fasting more than or equal to 5.6, 2-hour value more than or equal to 7.8. Insulin immediately if the fasting is more than or equal to 7. Target should be fasting should be less than or equal to 5.3. 1 hour should be less than or equal to 7.8. Okay. So please do not confuse this fasting 5.6, 7.8 with these targets. Okay. So these
Yes.
targets are 1
These are
hour
for
and fasting.
diabetes.
These are treatment targets. Okay.
Mm.
These are OGTT cutoffs. Okay.
Okay.
HbA1c will be done at booking and routinely it is not required after that. First drug in GDM is a metformin. Okay. So this finishes the topic of diabetes in pregnancy. Nice guideline. Thank you.